Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Many patients come to your clinic and asking about the role of DHEA or dehydroepiandrosterone sulfate or dehydroepiandrosterone in infertility, particularly old patients and near menopause. Should you prescribe this drug for them or not? This is the target of this lecture. You know that dehydroepiandrosterone is an androgen prohormone, which is mainly produced by the adrenal gland and also produced in the ovary and found in the brain as well. So, from this physiologic phenomena or physiologic criteria, we should expect that it may affect the adrenal gland if we give it to a patient affected the ovaries and also the brain. And we have to know that dehydroandrosterone and dehydroandrosterone sulfate are interchangeable prohormones, and they constitute most of the steroid hormones of the body. And you should also realize the fact that the adrenal glands and ovaries are the main source of dehydroandrosterone by its formation from 17-hydroxypregnenolone. And this dehydroandrosterone is around free in the circulation is less than the sulfonated form, which is dehydroandrosterone sulfate. So the dehydroandrosterone sulfate is 8 to 16 milligram per day and every day, while the free dehydroandrosterone is just 6 to 8 milligram per day. And actually, dehydroandrosterone sulfate is a storage form of this prohormone. It is the source or the father of an important hormone, which is androstenedione, and androstenedione has dual function by formation of testosterone in the theca cell and also estrone in the granulosa cell, and testosterone is changed into estradiol in the granulosa cells. So we have two forms of estrogen, estrogen 1, estrone, which is common in menopausal women, estradiol, which is estrogen 2, which is common in the reproductive age and important for implantation or fertilization. And also we have changing this estradiol into estriol, which is estrogen 3 in the liver and pancreas, which is a common estrogen in pregnancy. And recently, there are many publications on estetrol, which is estrogen 4, which is a natural estrogen produced by human fetal liver during pregnancy. So these are the sequelae of androstenedione. So androstenedione is formed due to dehydroepiandrosterone, and this androstenedione is a father of testosterone and two types of estradiol. We should know also that androstenedione is not only formed from dehydroepiandrosterone, but can be formed from 17-hydroxyprogesterone, and this is a common hormone in polycystic ovarian disease increased. So the androstenedione has dual function actually by forming testosterone and estrone, and testosterone is changed into estradiol, and also testosterone can be changed into active form, which is dihydrotestosterone. Now, what do you expect regarding the mode of action of dihydrotestosterone? The concept comes from the 2 points. The first point that it's mainly formed in the adrenal gland, so the main function should be targeted to adrenal gland insufficiency or deficiency of production of dehydroepiandrosterone sulfate. The second concept comes from the idea that dehydroepiandrosterone levels rise during puberty, peak during reproductive years, and then decline with age. So it has been suggested that high level of the plasma circulating dehydroaldosterone are suggested as a marker of human lung activity. So we expect that if you give dehydroaldosterone sulfate to a patient, it would improve his life or her life. And if we are giving it to an aged ovary, it will improve or slow down the process of ovarian or testicular aging as well. So the main line of treatment of dehydroaldosterone in females is in the field of infertility. And not all infertile women should receive dehydroaldosterone, but only the patients with decreased ovarian reserve or increased maternal age. Those patients will take this dehydroaldosterone, which is transformed into androstenedione, which is a father of testosterone and estrogens. So those patients will have increased androgen locally in the ovary, which would improve ovarian function and would improve fertility and improving ovarian reserve parameters and pregnancy outcomes. The support comes from the fact that dehydroaldosterone declines with age, as I told you. What's the exact mechanism of action of dehydroaldosterone on the ovary? It will lead to proliferation of granulosa cells, particularly the camellia cells with increased gene expression, and in the oocyte itself promotes folliculogenesis, and in the follicular fluid it will lead to enhancing level of follicular insulin growth factor 1. All these are the effects of giving the patient or taking dehydroaldosterone or the endogenous dehydroaldosterone on the ovarian functions. Importantly to know that regarding the oocyte promotes folliculogenesis by synergistic effect with the FSH on the growing follicles. So the growing follicles require androgens as well as the FSH to work on the receptors on the growing follicle to reach to the antral follicle just before the ovulation. And androgen receptor gene expression within the ovary is more pronounced in granulosa cell, expanding the follicles where its expression is enhanced by testosterone. So if the patient has decreased testosterone or dehydroaldosterone, a potential etiologic factor of reduced ovarian functions in the female, and this may lead to premature ovarian failure. As I told you, in the camellia cells, it will lead to, it has impact on the gene expression in these cells, and this is important for the ovulation. The camellia cells are pronounced or in the pre-ovulatory and just after ovulation. And you know, during IVF, after egg retrieval, the oocyte is surrounded by camellia cells. Also, it regulates immune functions, and as I told you, in the ovary, it helps to the FSH to work on the receptors of growing folliculogenesis, the increased rescue atretic follicles, increased follicle growth, and decreased apoptosis, in addition to increased insulin growth factor 1. So from these scientific backgrounds that it declines with age, we have to expect that it has a potential benefit on the ovaries by improving ovarian function and oocyte quality in patients with advanced age or patients with poor ovarian reserve, as found in many studies. The dose should be around 75 to 90 milligram per day for 2 to 3 months. One of the important studies found that combination of dehydroaldosterone with other adjuvant therapies is important for improving the ovarian function and oocyte quality and achieving pregnancy in addition to decreased dosage of gonadotrophins required for ovulation induction, by combination of it with the coenzyme Q10 and growth factor, as found in 19 trials on patients with poor ovarian reserve in around 2,677 women in a meta-analysis. If we compare it to coenzyme Q10, you can find the lecture on coenzyme Q10 and its role in ovarian aging. If you are asked to choose, or the patient asks you, is it better to take coenzyme Q10 or dihydroepiandrosterone, you have to advise her to take coenzyme Q10, because more research is done on the coenzyme Q10 and its efficacy in improving or slowing down ovarian aging is proved. And moreover, coenzyme Q10 is not contraindicated in polycystic ovarian syndrome, while dihydroepiandrosterone is contraindicated in the PCOS because they have increased androgens, testosterone, and so if giving her dihydroepiandrosterone, this will lead to androstenedione and increase androgens, and this will worsen the symptomatology of those patients. It has been used for many years as a potential treatment for women with perceived decreased ovarian reserve and poor embryonic development. What are the evidence? I already mentioned to you the randomized controlled trials, and here are 69 publications that found it shows some beneficial effect on ovarian camulus cells, improving oocyte quality of women with advanced age or with poor ovarian response. Other studies like Cochrane review found increased rates of live births, ongoing pregnancy, and a live birth rate. Another study increased pregnancy rate significantly in patients with decreased ovarian reserve. Some studies found no difference if they are analyzed only randomized controlled trials. But another study, recent study, analyzed the whole studies, including prospective and retrospective studies, and found significant improvements of all parameters, including pregnancy rate, apart from low live birth rate, and more oocytes and more metaphase 2 oocytes, fertilized oocytes, and top quality embryos. Some studies found that its use is not recommended because of the risk of androgenic as well as estrogenic side effects, so it is not a simple drug. And again, the DHEA guidelines in 2020 found that the use of dihydroepiandrosterone before and during ovulation stimulation is probably not recommended for poor responders. So in conclusion with this part, it can be used in alone or in combination with coenzyme Q10 or risk factors for those patients with poor ovarian reserve, with increased ovarian age or patient's age, for improving quality of the oocyte and enhancing pregnancy rate. The second function is in postmenopause. You told me that it declines after 30, so the postmenopausal women have low dihydroepiandrosterone. So if we give them this dihydroepiandrosterone, it will be a source of androgen, which is testosterone. And in those patients, usually it is transformed into testosterone rather than estrogen. What is the value? It improves the menopausal symptoms like libido change, muscle mass improvement, energy level increase, mood stability, and can be used also locally into the vagina as vaginal cream or gel, by this way passing the liver first the liver bypass. So this will lead to local effect, and this is advised in patients with contraindication to vaginal estrogen, because even if the estrogen is given vaginally, there are some circulatory level of estrogen, and it is not suitable for patients where estrogen is contraindicated. Moreover, if the patient is using aromatase inhibitor as a treatment of, as a co-treatment of breast cancer, so this vaginal estrogen is contraindicated because it will reverse the effect of aromatase inhibitors. In such a case, we also advise the patients to use vaginal dihydroamidal serum, either cream or gel. The third use in males, some males using the dihydroamidal serum as an athletic drug or athletic hormone, and also to increase libido. Its effect on the semen analysis is controversial. As I told you, it is found in the CNS, so many studies found that it has an important role in the CNS, and in many studies, it's used for treating depression and associated congenital disorders as a neurosteroid due to its potential neuroprotective, anxiolytic, and antidepressant effect. But put in mind that it is not a simple drug, it is a prohormone, so it has some risks. The risks for the female are androgenic side effects like facial hair growth, hair loss, and change in voice. In males, risks are coming from the increased estrogen level, estradiol level, from the testosterone, and this leads to decreased sperm production, in some cases testicular shrinkage and enlarged breast. In addition to some side effects on blood pressures, the liver functions, cholesterol change, some effect on the growth, or if a young patient using it, mood swings and increased in aggressive behavior were reported as side effects of the dihydroepiandrosterone, so it is not a simple drug. So some cases with increased or high level of dihydroepiandrosterone are contraindication to take the dihydroepiandrosterone supplements, particularly for PCOS patients with congenital adrenal hyperplasia, adrenal tumors, hyperprolactinemia, or chronic stress. So these are contraindications to the use, also adrenogenital syndrome, contraindications to the use of dihydroepiandrosterone. As I told you, in PCOS also, there is hyperandrogenic state due to the liver decreased sex hormone sex hormone binding globulin, increased insulin growth factor 1, increased 17-hydroxyprogesterone, and other causes, ovarian causes and non-ovarian causes of hyperandrogenemia. So it's not logic to give them a source of androgen again, which is dihydroepiandrosterone, and those patients with exaggerated response of 17-hydroxyprogesterone due to excessive insulin and insulin resistance. You can go back to the lecture on insulin resistance and PCOS. So serum 17-hydroxyprogesterone and dihydroepiandrosterone concentrations are elevated in PCOS affiliated or affected women, and their level must be related to the parameters of glucose metabolism. We can give dihydroepiandrosterone sulfate or dihydroepiandrosterone for patients with decreased level like aging, adrenal insufficiency, severe systemic disease, acute stress, or anorexia. In conclusion of this short lecture, we have to know that dihydroepiandrosterone is a prohormone. It is not a simple drug and should be used with caution. Ideally, you can give it to a patient with decreased level of dihydroepiandrosterone compared to her age, and that's why testing dihydroepiandrosterone should be put in your mind in all cases. And recent meta-analysis found that supplementation with dihydroepiandrosterone and coenzyme Q10 before IVF cycles is better than control. And as I told you, coenzyme Q10 is better than dihydroepiandrosterone sulfate. And regarding its effect in menopause, sexual functions, congestion, and overall well-being is a controversial issue and requires more studies. Thank you so much.